Welcome to the deep dive. Today we're tackling a really critical area. How doctors figure out if there are problems in the blood vessels heading up to your brain, specifically narrowing in the carotid arteries.
Yeah, carotid stenosis. We'll be looking at the different tools, the imaging techniques they use to actually see inside these arteries and, gauge how serious a blockage might be.
Think of it as exploring the different kinds of maps, maybe, that doctors use to navigate these crucial pathways. Some are quick checks, others give you incredibly fine detail.
That's a good way to put it. Each has its place, its strengths, and frankly, its weaknesses when you're trying to spot these potential traffic jams.
Exactly. And our guide for this exploration comes from a real authority. Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. We're focusing on the chapter about diagnostic evaluation.
Solid source.
Our goal today is really just to give you a clear, hopefully easy-to-grasp overview of how these different imaging methods work for diagnosing carotid artery stenosis.
Making sense of the tech, basically.
Right. Okay, let's dive right in. A common one to start, duplex ultrasound. What is that and why is it so useful here?
Okay, duplex ultrasound, or DU, it's like getting two views at once. You've got the standard ultrasound, the B mode, which gives you that black and white picture of the artery itself, lets you see the structure, any plaque buildup.
It's just the physical shape.
Right. But then the duplex part adds Doppler ultrasound.
Yeah.
And that measures blood flow, how fast it's moving, which direction it's going.
So it's not just static, it's looking at the dynamics. How does knowing the speed help detect a narrowing?
Precisely. Think about water in a hose. If you pinch it, the water speeds up right at that point, doesn't it?
Yeah, sure.
Same idea here. If blood has to squeeze through a tight spot, a stenosis, its velocity increases. We measure that speed, specifically things like the peak systolic velocity, PSV, and the end diastolic velocity, EDV.
Okay.
We look at those in the common carotid, the internal carotid, that's the key one going to the brain, and the external carotid. We also calculate a ratio comparing the PSV in the internal carotid to the common carotid.
So these speed numbers are the clues. Is there like a standard chart doctors use to interpret these?
Absolutely. Over time, experts developed what we call consensus ultrasound criteria. They're standardized guidelines looking at both the image and these velocity numbers to grade how severe the stenosis is.
Makes sense.
And they're particularly good, these criteria, for spotting the really significant narrowing, say over 70%. That's often a point where intervention might be considered.
Having that standard approach must be key.
Yeah.
So DU sounds really valuable. Why is it usually the first test people get?
Well, several reasons. First off, it's non-invasive. No needles, no cuts.
Good start.
It's also relatively low cost, and importantly, it's available pretty much everywhere. Most hospitals, vascular labs, they have it.
Okay.
And the big thing, it's actually very accurate for picking up significant stenosis. So accurate, in fact, that nowadays most carotid endarterectomies, that's the surgery to clean out the plaque.
Right. CEA.
CEA.
Yeah.
Most are done based just on the duplex ultrasound findings. That tells you how reliable it is in many cases.
Wow. That is impressive. But, like you said, everything has limitations. Where does DU fall short? What can it show us well?
Yeah, good question. It's our workhorse, but it definitely has blind spots. For one, bone gets in the way. So seeing the arteries way down low below the collarbone or way up high above the jawline, that can be tough.
Like anatomy limits it.
Also, something interesting, if you have a really bad blockage or even a total occlusion on the other side, the contralateral side, that can actually change the blood flow patterns on the side we're looking at, potentially making us overestimate how bad the stenosis is. The good side might be working harder, speeding up flow artificially.
So one side affects the reading on the other. What else makes it tricky?
Calcium. Lots of calcium in the plaque. It's hard, dense, and ultrasound waves don't penetrate it well. It casts a shadow, an acoustic shadow, blocking our view behind it.
By trying to see through stone.
Exactly. Makes getting accurate velocity measurements difficult sometimes. Also, telling the difference between a super tight stenosis, almost closed off, versus what's called a string sign, just a tiny trickle getting through that can be hard with DU alone.
Okay.
And one more thing, stents. If someone's already had a carotid stent put in, that changes the artery's behavior, changes the flow velocities. We have to use different adjusted criteria to read those scans correctly.
Right. Different rules for stented arteries. Got it. What about the other arteries in the neck, the vertebrals? One's going to the back of the brain. Is DU helpful there?
Its role is more limited for the vertebrals. We can sometimes see if the flow is going the wrong way, retrograde instead of antegrade.
Which might mean a blockage further upstream.
Yeah, like in the subclavian or innominate artery. But seeing where the vertebral arteries actually start their origins, that's often difficult with DU.
Yeah.
And further up, we only really see the bits between the neck bones.
So not a complete picture.
No. So if someone has symptoms pointing towards the back of the brain, the vertebrovascular system, DU is useful to check the carotids, sure, but we definitely need other imaging to properly assess the vertebrals themselves.
Okay, so DU is a great start for carotids, but not the whole story. Let's move to another technique. CT angiography, CTA. What's involved?
Right, MDCTA, multi-detector CT angiogram. This has been a huge step forward. It's basically a very fast CT scan using X-rays and an intravenous contrast dye.
The dye makes the blood vessels light up on the scan.
Exactly. And it gives us these incredibly detailed 3D images. We're talking sub-millimeter resolution. Plus, it shows not just the vessels, but the surrounding tissues, bone, everything all at once. It's a much more complete anatomical map.
That sounds significantly more detailed than ultrasound.
Yeah.
What are the big advantages of CTA?
Well, speed is one. It's very quick. It's great at showing abnormalities, even complete blockages. It also tells us a lot about calcification in the artery wall, how much there is, where it is. That's especially useful when looking at the aortic arch, where all these vessels branch off.
Seeing the calcium itself.
Yes. And, with modern CT scanners, the technology has improved so much that the radiation dose and the amount of contrast needed are actually lower than they used to be.
That's good to hear. So when would a doctor typically order a CTA instead of just relying on the ultrasound?
Often it's when the DU shows a kind of borderline or moderate stenosis, maybe in that 50–69% range, especially in someone without symptoms. DU can be a bit less precise there.
So for confirmation or better detail.
Right, or if we need to see the arteries further up or further down, then the DU could reach well. And crucially, it's become essential for planning interventions like carotid artery stenting, CAS.
Why specifically for stenting?
Because for stenting, you really need to know the whole roadmap, the shape of the aortic arch, the takeoff points of the vessels, any tricky turns or kinks in the carotid artery itself. CTA gives you that full picture needed to guide the wires and the stent safely.
And what about those vertebral arteries we mentioned? How does CTA fare there?
CTA is excellent for vertebrals. Because it uses X-rays, it sees right through the bone that hides their origins from ultrasound.
Big advantage.
Huge. It shows their origins clearly, any tortuosity, meaning twists and turns, and we don't have those artifact problems that can sometimes affect DU at the vertebral origins.
Okay, very useful. But what are the downsides, the limitations of CTA?
Main things are you need that intravenous contrast dye, which carries a small risk, especially for kidney function in people who already have kidney issues.
Contrast nephropathy.
Right. Also, unlike Doppler ultrasound, CTA doesn't directly tell you about the direction of blood flow. And there is, of course, some radiation exposure, though, as I said, it's generally low with modern tech.
Still something to consider.
And one more thing. If there's a lot of dense calcium, sometimes on the CT images, it can be hard to distinguish the bright contrast inside the vessel from the bright calcium in the wall. Makes measuring the true opening tricky in those cases. And maybe in really complex situations like multiple narrowings close together, or if the artery is supercoiled, CTA might occasionally struggle to give a perfectly accurate picture of every single stenosis.
Right. Contrast issues, radiation, calcium interference, important trade-offs. Okay, let's talk about the one often called the gold standard, digital subtraction angiography, DSA. If DU and CTA are so good, why is DSA still seen as the ultimate benchmark?
That's a fair point. DSA does still provide the absolute highest resolution, most detailed pictures of the blood vessels. But you're right, with DU and MDCTA being so good and much less invasive, DSA is really not needed routinely before surgery anymore. It's reserved for specific situations.
How is it actually done? Sounds more involved.
It's invasive. A catheter, a thin tube, is usually inserted into the femoral artery in the groin.
Okay.
Then it's carefully threaded up through the aorta into the aortic arch. Contrast dye is injected, first maybe into the arch, then selectively into each common carotid artery. While that happens, rapid X-ray pictures are taken.
And the subtraction part.
Right. The computer takes the X-ray image taken before the contrast went in, showing bone and soft tissue, and digitally subtracts it from the images taken with the contrast filling the arteries. What's left is just a super clear outline of the blood vessels themselves.
Clever. And how do you measure the stenosis from those DSA images?
The standard is the NASET method from the big North American trial. You measure the diameter of the artery at its narrowest point, the residual lumen, and you compare that to the diameter of the normal, healthy, internal carotid artery just a bit further downstream, beyond the stenosis. It's a ratio, and often they take pictures from several different angles to get the most accurate view.
Okay, so it's very precise. What are the advantages that keep DSA relevant, even if it's used less often?
Well, that image quality is superb. It's accurate, objective, usually easy to interpret. It can see everything from the aortic arch right up into the tiny vessels inside the brain.
The whole system.
The whole relevant system. It's particularly helpful when, say, the DU and the CTA or MRA findings don't quite agree. They're discordant.
To break the time.
Exactly. Or in tricky cases, like really severe disease, way up high in the internal carotid, near the skull base, or if the artery is sprecoiled. And here's a key thing. DSA isn't just diagnostic, it can be therapeutic too.
Right. You mentioned that with trauma.
Yes. If you find a problem during the DSA, like a clot causing an acute stroke, or bleeding from an injury, you can often treat it right then and there through the same catheter, maybe using clot-busting drugs, balloons, coils, or stents. That dual capability is huge in emergencies.
Diagnostic and therapeutic. That makes sense for specific acute situations. But being invasive, what are the risks?
That's the main reason it's not routine. Because you're putting catheters in arteries and injecting contrast, there are risks. The most serious, though thankfully rare, is causing a stroke during the procedure itself.
Yeah, that's significant.
There's also risk of bleeding or a bruise, a hematoma at the groin puncture site. And sometimes patients can have temporary or, very rarely, permanent neurological issues afterwards. The data from big studies confirms these risks.
So the bottom line is?
The bottom line is, routine diagnostic catheter angiography just doesn't have a role in standard cerebrovascular evaluation anymore. The potential benefit really has to clearly outweigh those risks for it to be justified.
Makes perfect sense. Reserve the big guns for when they're truly needed. Okay, let's shift gears to magnetic resonance angiography, MRA. How does this fit in?
Right, MRA. For carotid disease outside the skull, we mainly use two types. CIMRA, which is contrast-enhanced MRA using a gadolinium-based contrast.
Different contrast than CT.
Different contrast, yes. And TOF MRA, which stands for time of flight, and that one doesn't need any contrast at all.
Interesting. What are the general plus points for MRA?
Big advantages.
Yeah.
Totally non-invasive and zero ionizing radiation, unlike CT or DSA.
It's a major plus.
Huge. Plus, from a single scan, you can reconstruct images from basically any angle you want. And like CTA, but unlike DU, it can see areas ultrasound struggles with vessels in the chest or deep inside the skull. With special MRA techniques, you can even start to analyze the components within the plaque itself.
Seeing inside the plaque. That sounds potentially very useful.
Yeah.
Let's break down the two types. CIMRA first, the one with contrast. What are its strengths?
CIMRA often has fewer issues with flow-related artifacts, weird signals caused by moving blood compared to CT angiography. It also usually gives you a really wide field of view. You can often image from the aortic arch all the way up to the circle of Willis in the brain in one go.
Wow, that's comprehensive.
And sometimes CIMRA can give clues about the direction of blood flow, too.
Okay. And the downsides of CIMRA for carotid evaluation?
Well, it doesn't show the surrounding soft tissues as clearly as CT does, unless you add specific MRI sequences. Also, that calcium in the plaque, MRA doesn't define it nearly as well as CT. It can sometimes make calcium look like narrowing, leading to an overestimation of the stenosis.
So it might make things look worse than they are if there's lots of calcium.
Potentially, yes. And the big concern, the main reason for caution with CIMRA, is that gadolinium contrast. In patients with poor kidney function, there's a risk, albeit rare, of developing a serious condition called nephrogenic systemic fibrosis, or NSF.
Right, NSF. That sounds like a major deterrent.
Yeah.
What about the other type, TOF MRA, time of flight? No contrast needed there, you said.
Correct. That's its biggest selling point, no contrast agent required. It works by detecting the signal from moving blood. It can actually pick up signals pretty well even when blood flow is quite slow.
And you mentioned different types.
Yeah, there's a 3D TOF technique which gives better spatial resolution. That's helpful for measuring stenosis more accurately and also for looking at flow direction, like in a steal phenomenon where blood is being pulled away from one area to supply another.
So, no cross risk, good for slow flow.
Yeah.
Why isn't TOF MRA used all the time then, given the gadolinium issue with CIMRA?
Well, MRA in general, both types, just isn't as widely available as CT or ultrasound. Getting really high-quality MRA images, especially the ones needed for looking at the plaque composition, requires specific software, hardware, and expertise that not every center has.
Practical limitations.
Exactly. And that rare but serious NSF risk with gadolinium, even though it's primarily with CMR, has definitely tempered enthusiasm and led to MRA playing a somewhat more limited role in routine carotid workup compared to DU and CTA these days.
Understood. Availability and that NSF risk are key factors.
Yeah.
Okay, let's turn to something different. Transcranial Doppler, TCD. Sounds like it's looking inside the head.
It is. TCD is another ultrasound technique, but it uses lower frequencies that can penetrate the skull bone at certain windows, usually around the temples or the back of the head. It lets us look at blood flow in the major arteries at the base of the brain, the middle cerebral, anterior cerebral, posterior cerebral arteries.
So monitoring flow inside the brain itself in real time.
Exactly. It's rapid, non-invasive. We can measure flow velocities, look for changes, diagnose narrowings within those intracranial arteries. And this is important to detect tiny moving particles called embolic signals.
Emboli. Little bits breaking off and traveling.
Precisely. Maybe tiny clots or fragments of plaque.
So how does PCD fit into evaluating carotid disease in the neck? Is it used routinely?
Its routine role specifically for neck disease is fairly limited, mainly because most vascular labs just don't have TC capability as standard equipment alongside their regular duplex machines.
Availability again.
Yeah, but where it can be really useful is in diagnosing that spontaneous embolization. If we detect these embolic signals, often in the middle cerebral artery on the same side as a known carotid stenosis,
What does that tell you?
it strongly suggests that the plaque in the carotid artery in the neck is unstable. It's actively shedding debris. And that's a sign of a higher risk plaque, even if the narrowing itself isn't extreme.
Wow. So it's not just about how narrow the pipe is, but whether it's crumbling?
That's a great analogy, yes. And there's evidence linking this to stroke risk, even in people without symptoms.
Really? How so?
Well, several studies looked at asymptomatic patients with significant carotid stenosis who had TCD monitoring. A meta-analysis combining these studies found something striking. Detecting even one embolic signal during just an hour of monitoring was linked to an almost 8-fold increase in the risk of stroke later on.
8-fold. That's huge.
It is. So in those centers where TCD is available, finding these MLI in an asymptomatic patient might actually push clinicians towards recommending intervention, like a CEA, sooner rather than later because it flags them as being at much higher risk.
Fascinating. A potential window into plaque activity and immediate risk. Okay, we've covered a lot of tech. How do doctors actually put all this together? What are the clinical guidelines for using these tools?
Well, the Society for Vascular Surgery, the SVS, has pretty clear recommendations. The starting point, the initial choice for evaluating stenosis severity, whether you have symptoms or not, is duplex ultrasound.
DU first.
DU first, ideally performed in an accredited vascular lab, an ICAVL accredited lab, and interpreted by physicians experienced in reading these scans.
Experience matters.
Definitely. And if that DU study clearly shows, unequivocally, a 50-99% stenosis in someone with relevant symptoms, or a 70-99% stenosis in someone without symptoms, that's often considered sufficient information to make a decision about intervention.
So DU alone can be enough in clear-cut cases?
In many clear-cut cases, yes.
When would you need to go further, get that additional imaging, like CTA or MRA?
You'd typically need more imaging if the DU study wasn't technically adequate. Maybe the images were poor quality or it was non-diagnostic for some reason.
Okay.
Or if it showed that intermediate 50-69% stenosis in an asymptomatic patient, that gray area where DU is less precise. Or anytime you really need to evaluate the vessels either upstream, like in the chest, or downstream towards the brain, beyond what the DU could clearly see.
So filling in the gaps or clarifying uncertainty. What about screening people without symptoms? Should everyone get a carotid ultrasound?
No, not generally. The SVS suggests considering DU screening for asymptomatic stenosis only in specific high-risk groups and only if they are actually candidates for and willing to consider intervention if something significant is found.
Who falls into those high-risk groups?
People with known peripheral vascular disease, PVD, or those over 65 who also have coronary artery disease or a history of smoking or high cholesterol. Also, patients being evaluated before coronary artery bypass surgery, especially if they're over 65 or have certain high-risk heart conditions like left main disease or PVD.
So targeted screening based on other vascular issues or major risk factors.
Right. And screening is recommended for anyone who has had symptoms suggesting carotid territory ischemia, like a mini stroke or TIA or sudden temporary vision loss called amaurosis fugax, or if an eye doctor sees a Hollenhorst plaque, a cholesterol embolus in the retina, or if a brain scan done for other reasons shows an unexpected asymptomatic stroke.
But not just screening the general population.
No. Routine screening for asymptomatic stenosis in the general public, or screening just because a doctor hears a noise, a bruit in the neck with a stethoscope that's not supported by the current evidence or guidelines.
Okay, targeted screening, not widespread. Now let's talk planning. How does imaging guide the actual procedures, like CEA versus stenting?
For a carotid endarterectomy, the surgical cleanout, if the DU clearly shows that high-grade stenosis, 70 to 99% asymptomatic or 50% symptomatic with clear deficits, CEA can often proceed based on DU alone.
You mentioned that high percentage earlier.
Yeah, in experienced hands with good quality ultrasound, it's often sufficient. But for those asymptomatic patients in the 50–69% DU range, or if the DU seems unreliable in a symptomatic patient, then getting a secondary study, usually a CTA, is common practice to confirm the stenosis and check the surrounding anatomy before surgery.
Makes sense. What about the endovascular option stenting, either CAS or TCAR?
Ah, that's different. Planning for stenting, whether it's transfemoral CAS coming up from the leg or TCAR with direct neck access, requires much more detailed anatomical information than CEA typically does.
Why so much more?
Because you're navigating wires and catheters through the entire system for CAS or dealing with specific access site issues and flow reversal for TCA. Duplex ultrasound simply does not provide enough detail about the aortic arch, the vessel origins, the full length and tortuosity of the carotid, or the brain circulation.
So for stenting,
Either MDCTA or, less commonly, DSA is considered mandatory for preoperative planning. DU alone is insufficient.
okay, let's break that down. For traditional transfemoral stenting, CAS, what does the CTA need to show?
You need to know the aortic arch anatomy is a simple curve or complex. Are the origins of the great vessels clean or diseased? How twisty is the common carotid? Is there a safe spot, a landing zone further up in the internal carotid to place a protective filter device during the procedure? What does the circle of Willis look like in the brain in case flow gets compromised? CTA gives you all that.
A complete roadmap from arch to brain.
Essentially, yes. DSA could provide it too, but CTA is less invasive and usually the first choice unless there's a strong contraindication like severe kidney disease, or it's an emergency where you might go straight from diagnostic DSA to the treatment.
Got it. What about TCAR, the transcarotid approach? What's critical on the CTA for that?
With TCAR, the aortic arch details are less important because you're accessing the carotid directly in the neck, but the CTA is still essential. You absolutely need to know about the planned common carotid access site. How deep is it? Is there plaque or heavy calcium right there?
Because you have to puncture it.
Precisely. Heavy calcification at the access site is a major no-go for TCR. You also need detailed info on the ICA further up and the intracranial circulation. CTA helps select the right patients for TCR and avoid potential complications. The positive results from trials like Roadster and the big TCR surveillance project really rely on this careful, imaging-guided patient selection.
So CTA is key for both types of stenting, but looking for slightly different crucial details depending on the approach. What about trauma? You touched on this earlier.
Right. For injuries in zone 2, the middle part of the neck, DU can be a good screening tool and useful for follow-up if you're watching a minor injury. But MDCTA is really vital in trauma.
Right, vital.
Because it's fast and in one scan gives you the whole vascular picture from the chest up into the head, plus shows any associated bone fractures, soft tissue damage, or brain injury. You can do it even on ventilated patients. It's incredibly efficient.
And DSA in trauma.
DSA remains key when you suspect a more severe injury that might need immediate fixing, like a dissection, active bleeding, a pseudoaneurysm, or a clot. It allows for diagnosis and immediate endovascular treatment, like putting in a stent or coils.
Makes sense. What about those carotid body tumors you mentioned, the growths at the bifurcation?
DU is often great for the initial diagnosis. These tumors typically cause a very characteristic splaying or widening of the fork where the carotid splits. You see that on ultrasound, you strongly suspect a carotid body tumor.
But for planning surgery?
For planning, MDCTA is usually the best. It shows the tumor's blood supply, its full size, if it's on both sides, and exactly how it relates to the arteries and nerves nearby. All crucial for the surgeon.
Does DSA have a role?
Limited role routinely, but sometimes for very large tumors, DSA is used just before surgery for embolization, deliberately blocking off the main arteries, feeding the tumor to reduce bleeding during the operation.
Okay, we've covered before and during. What about after the procedure? imaging right after surgery, or stenting?
Well, during surgery, some centers use intraoperative DU right after closing the artery to check the repair. Look for any flap, clot, turbulent flow, but it can be technically tricky to get good images sometimes.
What about after closing the patient up?
Completion DSA isn't routine unless the surgeon has a specific concern about something further up. If a patient wakes up with a new neurological problem right after surgery, the first step is usually an urgent postoperative DU
A check for.
to check for a clot, a thrombosis at the surgical site. That's the most immediate concern. If the DU is clear, then MDCTA or sometimes DSA might be used to look for other causes, like an embolus that traveled higher up or even bleeding in the brain.
And long-term. How is imaging used to follow patients?
For long-term follow-up, the SVS recommends a baseline DU within about a month after CEA. After that, further DU surveillance depends on those initial results and the patient's risk factors. If a later DU shows significant re-narrowing, usually defined as over 80%,
Then what?
then typically an MDCTA would be done to confirm, and intervention might be considered again. For stent patients, the follow-up is similar DU at 1 month, then maybe every 1 to 2 years, but using those adjusted velocity criteria specific for stents. Again, if stenosis looks significant, 80% or maybe 50% if they have symptoms again, further imaging and potential reintervention follow.
So DU is the main tool for surveillance,
Yeah.
with CTA stepping in if problems arise.
Okay, looking ahead now, what's exciting? What are the future directions in carotid imaging? A really big focus now is shifting from just measuring how narrow the artery is to evaluating the plaque itself. What is it made of? Is it stable or unstable?
Getting beyond just the percentage stenosis.
Exactly. The goal is to better identify which people with asymptomatic stenosis are truly at high risk for stroke. We're seeing computerized analysis of DU images, looking at plaque texture, things like grayscale median, plaque area, juxtaluminal black area, trying to find markers of risk.
What about CT and Mylar?
MDCTA is already good at spotting ulcers in the plaque, which are a risk factor. And SEMRA, despite its limitations, is proving useful in research for visualizing things within the plaque, like internal bleeding, intraplaque hemorrhage, thrombus, or a ruptured fiber scap. These features are strongly linked to plaque instability and stroke risk.
So the future might involve.
The future might involve using these advanced techniques, focusing on plaque morphology and composition, to decide who needs intervention based on having an active or high-risk plaque, not just based on the percent narrowing.
That's a potentially huge shift, focusing on the biology of the plaque, not just the mechanics of flow. Okay, to wrap this all up, what are the key takeaways from our discussion on diagnosing carotid disease?
I think the main points are duplex ultrasound is definitely the first-line tool. It's non-invasive, accessible, and often gives us the answer.
But it's not always enough.
Right. CT, MRA, and occasionally DSA play crucial complementary roles when DU has limitations or when we need more anatomical detail, especially for procedural planning. CTA, in particular, is becoming more and more important with the rise of stenting, especially TCAR.
And the overall impact.
The overall impact is that having these tools, especially readily available DU, allows for really rapid, safe, and accurate evaluation, speeding up diagnosis, and getting patients the right treatment faster.
It's a really impressive toolkit, a multifaceted approach with DU leading the charge, but sophisticated backup when needed. It really makes you think about how far medical imaging has advanced. For everyone listening, was there one technique that stood out to you as particularly surprising or clever in how it's used?
Yeah, it's pretty amazing technology.
If you want to dive even deeper, you can look up the specific criteria and guidelines from organizations like the SVS. And here's a final thought to mull over. As this imaging tech keeps getting better, focusing more on the plaque itself, how else might our whole approach to finding and managing stroke risk change in the future? Maybe moving even further beyond just that percentage of blockage. Something to think about. Thanks for joining us on The Deep Dive.